When Sarah and I were talking about putting together this presentation, one of the things we were talking about was how when we meet these newly diagnosed HIV positive people, very often we don't talk about HIV at all. It's not coming into the room very much. There's all, and Sarah's going to get into it a lot more later, talking about a lot of the issues that face our clients. But it's so. Just so you know that again, it's listening to stories, it's helping people, it's making a difference and making a change, a positive change for people. And sometimes the HIV is front and center, sometimes it's just incidental, but I think it's important to know that.
Sure. So Jordan's already touched on it a little bit, but just to give you a quick snapshot of what we're going to talk about over the next hour or so, Jordan's going to speak to just how do we value each other as human beings. The current state of HIV, themes around being newly diagnosed, what could come up in the room when you're meeting with your clients. So we're going to talk about stigma in depth, discrimination, themes of shame and guilt. We're going to talk about what an adjustment disorder is and how that's different than a diagnosis of depression or anxiety or PTSD. And I know that you've had other talks on that so far in this series. We're going to talk about different interventions that you could use with your clients at various stages. And then we have some case studies for you at the end where we're really just going to open it up to everybody. Jordan and I are really informal, so if anyone has a question or a comment, feel free to interrupt. We welcome that.
Does anyone have a question or a comment so far? No? Okay. All right. So, it's important that I think that we always ask these questions of ourselves when we're sort of looking at the context of working with anyone else, and then just try to understand what people are going through. So, I put together this list just to sort of ideas that I had around this. It's in no way exhaustive, but it's the idea around how do we value people? How do we value ourselves? How do we value other people? Just generally, when we think about it, is it around our family or maybe money, joy that we bring to ourselves or other people, our work or friends, excellence, functionality, that's a big one, it feels to me, functionality, appearance, education, charity, compassion, possibly. But how, when you think about it, when you think about how do you value other people in society, because I think this is an important piece, as well as yourself, because the question isn't so much how do you value people, the question becomes, what about when people don't meet these criteria? What about when you don't meet these criteria? Then what? Are you less? What happens then to the value and of yourself or the way you see other people? I think it's important to sort of think about that, not so much how you value other people, but what if that criteria isn't met? Then what do you think of those people? So I want to talk just for a second, and not to be too incendiary, about how HIV is not special. So I've worked for the last almost 14 years at St. Michael's Hospital in the positive care clinic there, and I have really seen HIV change over the years, and new medications, treatments, things like that. When I first started working there in our outpatient clinic, it was 300 people that would cycle through there. Now we're close to 2,000 people who come there. So the face of HIV has changed in my tenure in working with it. So I just want to say HIV is what's considered a chronic disease, right? And there's many chronic diseases that are out there, and I just listed a few of them that are other chronic disease that people get. And again, by no means is that an exhaustive list. But HIV doesn't have a mind of its own. It is a disease. It's something that people get, and then, but in no way is it any more or less special than any of the other chronic diseases. And in fact, the treatment options and the way people are responding to medication these days, it's not it's in no way is it worse than a lot of the other diseases. So I always like to say, and it's also sort of trending. We know this in terms of funding and things like that. That as treatment options and efficacy of medication increases, we're seeing less funding and things like that around HIV. So that is something, of course, all of us in this room are probably taking special note to. But why HIV is special? And, you know, I've thought about this and talked to a ton of people about this for a long time. And there's something, and the argument always is when I talk to someone and you make a newly diagnosed person, you're always making the argument around, the disease trajectory and such. And you're talking about, well, you know, maybe there are some other chronic diseases that you could have got, and you wouldn't feel so awful around issues of disclosure in that, for instance, diabetes or anything I had on that other list. But there is something special about HIV, right? There's something very special about it that prevents people from disclosure and a lot of other things we'll be talking about. So as I've talked to people, it seems there's a few themes that come up. One is it has the word acquired in it, right? And acquired in the word AIDS. And the word acquired has connotations around behavior. You've acquired something. You've done something to acquire this, right? That it's transmissible. You can't catch diabetes, or you can't catch cancer, things like that. It doesn't transmit. One person has it and you give it to someone else, but HIV does. That is certainly a part of it. And we all like to define ourselves as sexual beings. That's sort of one of the things that we all have in common in this world. So because of that, it's become this frightening thing because it's related to sex. And I think that that's sort of a key to why people are freaked out about that.
So you have a client who walks in, they're newly diagnosed. You're going to be hit with any number of things, as I'm sure you're all familiar with. There can be a number of questions that come up. And again, none of these lists I'm going through are exhaustive lists. How did this happen? The learning curve around tests, around knowing what the blood tests mean, around medication, what the options are, any treatments that the person has to go under. Who do I tell? How do I tell? How is this going to change my life? What is my life expectancy? How is that going to change? How is this going to affect my relationship, my future relationships? And so many other questions. We've written down a bunch of themes that could come up at any given point when you're meeting with your clients. Issues around disclosure, around transmission, around stigma, and that's something that Jordan's going to talk about in depth in a little bit. Coping with infections that people might have, different lifestyle changes that people might be considering or that might be dictated by their healthcare team. Coping with infections, lifestyle changes, treatment decisions, substance use or abuse issues that they may come into the sessions with, or substance abuse issues that arise after diagnosis as a way of coping. Medications, adherence concerns. People may come in and have issues with their relationships with their healthcare team. I don't like my doctor. I don't have rapport with my doctor. My doctor doesn't listen to me. And that's one way that we could really support our clients in how to navigate the healthcare team, how to ask questions. Self-esteem and identity issues. Client may come in with self-esteem and identity issues. Self-esteem and identity issues may come up as a result of the diagnosis, really just sort of giving the client some space to be able to explore some of that with you. Issues around control and uncertainty. That's certainly a big one. How this is going to impact on their current relationships. Different ways of coping. How have I coped with stress and distress in the past? How am I coping now? Maybe I'm not coping now. Dealing with loss and grief, loss of the idea of what my life was before, loss of what I thought my future was going to look like, grieving what my life used to be, if it feels like there's an enormous change. dealing with symptoms of depression, anxiety, trauma, whether it's pre-existing or symptoms that come up as a result of the diagnosis. Themes around why me, denial, shame and guilt, which again we're going to talk about more, abandonment. If they have supports, people may lose those supports. They may feel abandoned by friends, by family, by loved ones. Issues around betrayal, dependency. Again, some clients, very independent, dealing with, well, maybe I have to rely on other people. I don't want to rely on people. That's not something that I do. Loss of this idealized future that they may have had before, fear of dying, and certainly employment and financial concerns can come up too. And again, not an exhaustive list. So many other themes that can arise.
I'm just going to talk for a little bit around this idea of stigma, because I think that that is the sort of the piece that I feel I deal with the most when I'm dealing with clients. I would say certainly it's the one theme that comes up across every population, every culture that I'm dealing with for sure. So I'll just read this. It's the extreme disapproval or discontent with a person or group on socially characteristic grounds that are perceived and serve to distinguish them from other members of society. Stigma then may be affixed to such a person by the greater society who differs from their cultural norms. So there's different kinds of stigma. I'm just going to go through them. I feel like we've said this is in no way an exhaustive list too many times, so I won't say it, but let's just imply it. So this idea around AIDS being a punishment for bad behavior, or just as recently as 2 hours ago, I was with a client who was telling me that, and it was an interesting argument she was making, that it was a punishment from God that she became HIV positive, and she is now choosing at the moment not to take medication for it because her trust is that her punishment was getting HIV, and God will take care of her and protect her. So she doesn't need to take medications around that. But that's not one of my case presentations, so I don't need to talk about that anymore. A person with HIV must have done something wrong. I am most fascinated by that point. I think that is a really interesting point that I'm going to speak on a little later. It's the one that's sort of obsessing me lately. People who get HIV through sex or drug use have gotten what they deserve. People with HIV should be ashamed of themselves. So, this idea of stigma, as you know, is one of us versus them, and it's truly the basis of all fears, I think. And we can sort of see this idea of us versus them has been used historically to dehumanize people, and that is, which is currently happening right now. This has been a crazy few weeks around the world, around things around human rights and governments killing people and things like that. And it all has to start somewhere. And for this sort of action to be legitimized, people need to be looked at as scapegoats. And to scapegoat someone has to be all about they are different than we are. They're not people. They're different. There's something less about them than us. So it doesn't really matter what we do. And that, just look to history to prove that. So there's this idea of externalized stigma, the stigma that comes from, not from you, but from around you. It's this idea around people have told me that getting HIV is what I deserve for how I lived my life. When people learn you have HIV, they look for flaws in your character. Most people believe that an HIV person who has HIV, is dirty or disgusting. This can only lead to negative outcomes. When you have sort of this negative treatment and judgment on people, then there's no way that it can learn. And in fact, what it does lead to is this idea around internalized stigma, right? I always say you need to have externalized stigma before you can have internalized stigma, because children as we all were different years ago, you're not born hating others or hating yourself. That's all learned behavior. And so when there's so much messaging done to you, you can't help for it to become internalized. So, you hear statements like, sometimes I feel worthless because I'm HIV positive. I feel guilty. I feel I'm not as good a person as others because I have HIV. And having HIV makes me feel that I'm a bad person. And I have to say that I do deal with that sentiment a lot. That's one of the overriding ones, I'd say. So there's this will all, of course, lead to public discrimination, what I was sort of like talking about a little earlier. People are excluded from social gathering. Sorry, Sarah, can you hand me my water? Abandoned by their spouse or partner, verbally abused or teased, physically assaulted, fired from work, had property taken away, been denied health services. I'm just going to talk for a minute about one of my outpatients that I work with. This man who gave me permission to tell this story, but I won't name him. He acquired HIV through blood transfusion for his bleeding disorder 25 years ago, something like that. And in fact, the province of Ontario now pays him money every year for it. So that's how he became HIV positive. Growing up in small town in the Kawarthas area, his parents felt this sense of shame around him and sort of raised him never to disclose to anyone. Don't ever talk about that. That's a little dirty secret that we will not share with anyone else. And specifically, his mother was very present in his life, and predominantly that was the message that she would send. As he was in his 20s, he heterosexual. He would sleep with women, have sex with women. Some women he would disclose to, but he realized that the results of that weren't so great for him. So then he slept with some people and did not disclose. And when one of these women found out, she came forward, went to the police, and he was arrested, and he spent the night in jail and appeared in court. And the next day after that, no trial had happened, no decision had been made through the court. Two of the local newspapers had his picture on the front page with words around sexual assault, sexual predator. If anyone knows of this dangerous person's behavior, please come forward. The trial happened, and he had to do some months in jail and parole, probation, so on. It's a sweet young guy. He talks about that being the worst part of this entire experience was the public shaming around it, was his photo being in the newspaper, losing all his friends because of this. The trial hadn't even happened yet, and the police were already reporting it with the press and his photo and such. So it's this idea around the externalized stigma that will lead to public discrimination. Just that. So then you hear stories around healthcare discrimination, and Sarah talked about that, receiving less care and attention than other patients, using latex gloves for performing non-invasive exams on clients. Very often it'll be left to the junior provider when they come into the hospital. Healthcare providers gossiping about a client's HIV status. I have actually witnessed this I was in a completely unrelated, in a fracture clinic for myself because I'd broken my collarbone. And I was sitting there, and in these fracture clinic rooms, it's basically you're like a little cot, and it's kind of like a slot with a sheet between you and the next bed, and there's like a ton of them in the room. Well, the person next to me, the resident, was saying to this guy, medical history questions, and this was an older guy, probably in his mid-70s, and so he had a woman who was with him who was answering the questions, some sort of PSW, personal support worker, and she was saying, well, yes, and he's HIV positive. And the doctor stopped and he said, sorry, did you say he's HIV positive? Not even talking to the patient. And she said, yes. He said, okay, he's HIV positive. She's like, yes, that's what I said. And he looked at the patient, he said, how did you get that? And the inference was because he was like a man of, a certain age that, how could that possibly happen? Anyway, I went on to report this to the senior doctor that day, but that's not an uncommon practice. And this was in a hospital that definitely should have known better. The problem is, of course, logistically, it's a teaching hospital. There's a million residents that come through, and you can't tell everyone all the time, but you would assume that this sort of thing doesn't happen anymore. Then there's the issue around personal discrimination, being excluded from a social gathering, abandoned by your spouse partner, verbally abused, physically assaulted, fired from your work, had property taken away, been denied health services. I hear all of these stories that are happening both in Canada as well as other countries, like just really horrific stories around this. And the one I probably most hear is really so frustrating because it's people who get fired from their job when they have disclosed, but they can't prove that that was the reason the person fired them. But the crazy part is, up to that point, they've gotten along so well with their employers and their coworkers and that. And then once that information was out, they were fired for like other unrelated reasons. And so it's very frustrating because they can't really fight against that. I try to lawyer them up, but still it's hard. So this idea around external stigma of HIV is primarily based on a lack of education. What I was saying before, the whole better you than me. And so I think it's important to also look at not just the stigma around HIV, but also the stigmas around mental illness. I'm not going to go into this too much, but it certainly is a huge stigma that is separate from the stigmas around HIV. I'm a believer that every single person in this world confronts mental illness in their own life at some point. And it's just some are milder and more severe, but all of us. Think of your own life, of some horrible thing that had happened to you and how you coped and times you felt you couldn't cope, and that there is no difference between that and someone who has some hard diagnosis. But I think that the stigma around mental illness is people are so freaked out about it, and it's such a scary idea for people that they're afraid to talk about it because somehow if we talk about it enough, then it will happen to us. That somehow if you share your despair with me, it's going to trigger my own despair, and then what? And there's also a lot we don't know about how the mind works and how mental illness comes about around genetics, environment, and things like that. So there is, as you know, a huge stigma around mental illness and not just HIV. But, we're seeing, Sarah and I are seeing, and probably a lot of you are seeing people that have both issues that are happening concurrently, right? HIV, which can lead to depression and anxiety. And so even though you can think sort of through that argument logically, the emotional impact of this external stigma will generally always lead to the internal stigma. So how you react to this, right? When you're facing all this stigma in your face that's happening so often, how does one react to it? So this idea of the fear of the unknown, I think, is a huge one that I'm always dealing with clients about. HIV is also very new. We've got to remember that. It's only sort of first come into public consciousness in the mid-'80s and such, and even then, not really till the mid-'90s, I would say. But this idea that HIV is a death sentence, and even though that's no longer true, statistically speaking, it's still sort of the idea that persists in people's head, and it's this fear of unknown, and that this idea that everything is going to change in your life. and I think Sarah's going to talk a bit about that a little later. But the idea that like everything I knew yesterday was different than it is today when I was diagnosed with HIV. That everything is going to change. And then there's this idea of loss. Now, when I talk about loss, people always think, oh, you lost someone, like the death of someone. But that's not what loss is. Loss is the loss of can be anything, which could be a job. It could be a relationship or, a spouse. It could be loss of my home, loss of my comfort, loss of my sexuality, my sense of identity, all of that stuff, right? It's this idea around loss. And we know people grieve when they lose something. They go through that process, and there is no difference here, and it doesn't matter what your loss is, in my experience when I'm talking to people. And just this idea of dependence that Sarah also talked to a minute ago is huge. I now have, I had an inpatient I was talking to last week who is looking realistically at the loss of function of his legs. And he was gainfully employed as a chef. And, it's sort of really getting into this idea around dependence and what that means. And I know myself, when I've broken a leg or arm or something, even something, benign like that, when I have to depend on someone like, oh, can you just hand me that glass, please? It feels like such a drag because I value my independence, my ability to function independently. And when I have to rely on someone else and give up that independence, that is a awful and frightening thing. And we really should look at that as important. So this is a piece that I was talking about earlier that I'm the idea that I'm sort of obsessed with recently, because when I talk to people about their HIV diagnosis, a lot of times, over and over, and I'll be talking to the greatest people in the world, tell me that they carry a lot of what I was speaking to earlier, a lot of shame or guilt or the stigma around becoming HIV positive. I just talked to someone last week who was telling me, he's like, I'm a kid of the 80s, I knew better. The messaging was effective with me. Always wear a condom, don't have unsafe sex. And yet I did a couple of times. And one of those times made me HIV positive. And it's like, I'm just, and then it's all those horrible self-shaming words like stupid and idiot and awful and deserve it and things like that. And it just, intellectually, I just can't stop that idea from going on over and over in my head. And so I started thinking about this, and then I thought, okay, we are all people that engage in different behaviors in our life for whatever reasons that come to us. So some of these behaviors we knowingly walk into that we probably shouldn't. We know better, what have you. And there are certain, I put it in quotes, bad behaviors that are acceptable in society. And so I put together this list, which is exhaustive, by the way. No, I'm kidding. And there's certain behaviors that we do as a people that don't hold the same judgments around it, right? Don't hold the same stigmas and things like that. So I put down things like eating too much. And we know statistically that most healthcare dollars are related to this. That's where most of our healthcare dollars are spent around health issues around eating too much food. And then there's polluting, right? There's people who drive cars out there, and we know that those are horrible for the environment. Use plastic, oil, pesticides, things like this, right? Chemicals every day. We know we do this, and we still do it. Then there's this whole issue around addictions. And then there's a hierarchy around the things that we can be addicted to. Some are worse than others. So I wrote down gambling addiction, sex addiction, which includes safe and unsafe sex, substance addiction. And now let's look at the subcategory of that. So if you're addicted to cigarettes or alcohol or marijuana, that's probably not as bad as being addicted to crack or meth, heroin, ketamine, ecstasy. I very often counsel people who have substance use issues around this stuff. And when I was speaking to a client last week, And he was saying the thing is that, he knew better and he shouldn't have done it. And, oh, he did it and how stupid he is. And I said, well, let me show you something. And then I pulled open the blinds, and it was that day when, doesn't matter because we're all stuck in this winter forever anyway. The snow was just hard driving, like it was going sideways, and it was like a huge blizzard. And I said to him, I rode my bike to work today in this. I rode it. And he looked at me, he's like, are you crazy? And I said, well, let me beyond crazy, because maybe that's got nothing to do with it. I actually had a cognizant thought in my head. I stood in my window and I looked out and I saw it was snowing this hard, and I thought to myself, should I take the streetcar? Oh no, I'm gonna ride my bike. I hate taking the streetcar, which I do, makes me homicidal. But I could ride my bike. It probably wouldn't be so bad. I just have to get to college, which is close to me, and then it's up young, and I can do it. But I had this thought, and every time, I'm not kidding, every time I was like pedaling, it was like, this is stupid. This is stupid. Shouldn't have done this. This is stupid. Well, I'm already committed. I'm not going to turn back now. And I did it, and I got to work. What could have happened to me, right? And yes, I listened to music on my iPod. What could have happened to me was I could have been hit by a car. It could have been whatever, dead or hurt or something like that. And yet, I can assure you, voluntarily committing to this stupid behavior would not have been judged nearly as harshly as a lot of other things that we're talking about, specifically someone getting HIV. And so I told this guy this story about my stupid bike riding that day and tried to put some sort of context in this around what are stupid things we engage in every day, and how do we judge around that, right? Because we do that. We all do stupid things, if you will, or things that we know better about. And we judge what those odds are in our head, and yet we still engage in that. So why do we have this hierarchy around some being worse than others, right? So it's this idea of what's acceptable to ourselves and what isn't, and what aren't. So I kind of see that as like a stigma scale, if you will. It's a complicated issue because it's around people, and every time people are involved in anything, I think things don't get more complicated than that. So, we're all sexual beings. In this room, of any, I don't need to talk about the diversity of what that means of around gender and sexuality and things like that. I'm just assuming you're all with me on this one. But we still live in a world where it's illegal to be gay in 76 different countries. You go no further than today's hot headlines of what's happening in Uganda, which is literally the story I woke up to this morning on the CBC, where they just a couple of days ago named the top 200 gay people in Uganda the day after the bill was made law and passed that it's illegal to be gay. So, we're hearing stories about people, any kind of advocacy over there, living in fear that I can't imagine what that's like, as well as stories of people in smaller towns and that being dragged out into the street and beaten, sometimes to death. The whole Sochi thing, all of that, I don't need to go on. The other thing is, as I was sort of saying about mental health, that's another piece, is that it's fluctuating. So you could be depressed right now and tomorrow not be. And it's the same with any of the other sort of mental health issues that people experience. It's a fluctuating thing. It's not just one static or stagnant issue around that. And I have to say that almost 100% of clients that I counsel are experiencing at some point since diagnosis anxiety and or depression. I would say 100%. That number's not too crazy. So I'm just going to talk a minute about shame, because I think it's very important and something that, as I was alluding to earlier, a lot of our clients are going through. So this idea around the stigma, the external stigma that leads to the internalized stigma, will manifest itself as either, generally speaking, as either something called guilt or shame. So guilt is something that you did. I feel bad for doing something. Shame is when you own it. It's a part of what you are. So if you stand someone up, you could say, and this is shame, I'm an idiot. I'm a terrible friend. I did that to you. Where guilt is, I can't believe I did such a terrible thing. What a horrible thing I just did, right? So it's all about sort of the ownership as opposed to something you did. So it's something you are as opposed to something you did. So that's sort of the quick definition. When we feel shame, we know this, that one of the things that we go through is a disconnection. We feel, when we feel true shame, we're disconnected from others. It's a bad feeling. We feel so shamed about it that we don't want to tell anyone what we did. And we sort of walk around carrying that burden around it. And this will very often lead, as if I think a bunch of us in this room are service providers, what we will see to self-destructive behaviors in people when they feel such deep shame, and maybe even try to shame others. So there's this quote by Brene Brown in her book, Daring Greatly. And I've kind of drank the Kool-Aid on her stuff, but not 100%. If we don't come to terms with our shame and our struggles, we start believing that there's something wrong with us, that we're bad, flawed, not good enough, and even worse. We start acting on those beliefs. If we want to be fully engaged, to be connected, we have to be vulnerable. In order to be vulnerable, we need to develop a resilience to shame. And so when I'm talking with the clients out there, I talk about their behavior as something that they did, not something that they are. And I try to connect with them on that level, because we know from research done on shame that when connection is made, when someone feels disconnected, they need to feel reconnected in order to get away from those ideas around shame. And now I feel I might even pass. What?
Jordan's done a great job of really setting the stage to give us a flavor of the context that people are walking in with. In varying degrees. So I'm going to shift gears a little bit and talk about the clinical stuff. We have a client that walks in, they're experiencing some level of distress. They could have depression, they could have anxiety, they could have post-traumatic stress, they could have substance use or abuse issues. So what are we going to do with that? And actually, I just want to ask Jordan to quickly mention a Canada-wide needs assessment that he was a part of.
So a couple of years ago, I traveled across Canada, and I was teaching HIV and mental health to service providers. But before I did that, the place where I was working for, we did a Canada-wide needs assessment to see if indeed the curriculum that I developed was appropriate to teach to these people. So we did this Canada-wide for PHA's survey, and the question was, from diagnosis till today, which of the following mental health issues have affected your life? And we got back, I don't know, somewhere 200 and whatever it was, responses. And I would have bet money that the number one response would have been depression, but that wasn't. That was number two, distantly, and number one was anxiety. Anxiety is the number one issue that people who have been diagnosed or who are living with HIV experience by a huge margin. Almost every single person responded that anxiety was something that was a significant factor in their life. And I would say, I wish I had it in front of me, but somewhere in the neighborhood of just under 50% reported depression.
And that's something that we started talking about when we started working together again over at Maple Leaf is, what kind of cases are you seeing? What kind of cases are you seeing? And there's been all of this talk around depression and symptoms of depression that people are experiencing. And what Jordan and I have found, at least clinically, is that people are coming in with a ton of anxiety, whether it was anxiety that they had before the diagnosis, whether it's anxiety that sort of played into finding themselves in a situation where they were at risk, or anxiety that's developed out of being diagnosed with HIV and coping with that and coping with life changes. So that's something that we've just found kind of fascinating in our own practice. So one thing that I wanted to mention, the words anxiety and depression and trauma are thrown around a lot when it comes to talking about mental health issues in HIV. And my bias is to not over-pathologize my clients. That happens enough. We don't need to add any extra. And when somebody's first dealing with their diagnosis and trying to make sense of it, it really, more often than not, is an adjustment disorder. It's a situational depression or situational anxiety. So we want to be careful that if we see symptoms of depression or anxiety or trauma or a whole host of other things, we don't want to over-pathologize. We don't want to label them with an extra diagnosis that may or may not be appropriate. They may have comorbidities. They may have a pre-existing depression that they're coming in with. But a lot of the time what we're seeing is a difficulty adjusting to the diagnosis. And the treatment is going to be a little bit different as such. So up here, I've just got the definition of what an adjustment disorder is. So it's a psychological response to an identifiable stressor or stressors that results in the development of clinically significant emotional or behavioral symptoms. It's usually within 3 months of the onset of the stressor, and this can look like depressed mood, with anxiety, or with a conduct disturbance, and what the DSM labels that as things like fighting or vandalism, reckless driving, or a combination of any of these things. And an adjustment disorder can be something that's short-term, or it can be something that's long-term, but it's situationally specific. So we get a client that comes in who's high functioning, has varying degrees of stress in their life, but they generally cope pretty well. They find out that they've been diagnosed with HIV, and all of a sudden they can't get out of bed, they can't go to work, they have unbelievable anxiety, they're experiencing panic attacks. That's something that we would say, well, I wonder if that's an adjustment disorder, as opposed to labeling them with a major depressive episode or generalized anxiety disorder or a panic disorder. And up here, I've just thrown up a bunch of other things that Jordan and I both see in our practice. Things like generalized anxiety disorder, and I'm not going to go into all of the nitty-gritty criteria. You may already know about these or had other presenters talk about it. But generalized anxiety disorder is where worry is kind of a moving target. The worry or anxiety can be focused on anything. Social phobia or social anxiety, that's something that I've seen a lot, certainly in our work at Maple Leaf. It's something that's really socially isolating. It's hard to talk about disclosure if somebody's feeling really, really anxious around people, or being embarrassed, being humiliated, or just even being out in public. A major depressive episode, which I know you've had to talk about, PTSD, complex trauma. I know you've had to talk about that already. Bipolar disorder, somebody who's in a manic episode, panic disorder or panic attacks, certainly not uncommon. Obsessive compulsive disorder, or where issues of contamination may come up. So if somebody has pre-existing OCD, a diagnosis of HIV, where if they have contamination issues, that could certainly end up going up. Addiction issues, and certainly there are others that we can see walking in the office. So what can I do when my client walks in? What are some of the interventions? So I wanted to just talk briefly about different approaches that we can take, and then talk a little more specifically about some techniques that we can use and strategies that we can give our clients. So this is just a few. Certainly client-centered approach is always a good place to start, just unconditional positive regard. Being there for our clients and providing empathy and support, and just giving them a space where we can listen and they can talk. Cognitive behavioral therapy, that's talked about as sort of the evidence-based strategy. And certainly CBT works really well. I don't live and breathe it, but there are some things that CBT does really, really well, particularly looking at catastrophic thoughts, overly negative thoughts, overly anxious thoughts. And it has some good structure around behavioral interventions, because sometimes looking at the anxious thoughts or the negative thoughts is too hard for clients, and an easier place to start is with, okay, well, let's start by structuring your day. Let's start by getting out of the house. Simple behavioral stuff that we can do. Emotion-focused therapy is one that I'm quite partial to, that looks at emotions as sort of the base for everything, working with feelings as opposed to working with thoughts, focusing on attuning to our clients, meeting them where they're at. Also a feminist approach, certainly a multicultural approach, existential approach. There are lots of different frameworks that we can work from to be helpful to our clients. For me, I always start, where do I start? The best place to start is a place of empathy, trying to put ourselves in our clients' shoes. We may have some kind of case conceptualization or expectation of what our clients are going to walk in with based on the context that Jordan's talked about or based on the clients that we normally see. But we really don't know who's going to walk in the door and what they're going to want to talk about and what they're going to be ready for. So by starting, from a place of empathy, I don't think we can really go wrong. Validating the client's experience, really, really, really important, especially if they're not getting that elsewhere. Normalizing, some people will come in and they won't be able to make sense of what they're feeling and what they're thinking, and just sort of letting them know that this is not the first time that you've heard it, that they're not going crazy, that other people have been in this place. And also modeling a supportive relationship. The therapeutic alliance is a really important one for many reasons, but being able to model what a healthy, supportive relationship is like, it's going to help give your clients tools to recognize that out there in their own support network, or help them to seek it out if it's not currently there. Identifying coping strategies is something that I do right off the bat. Somebody's sitting in my office, I'm going to have to give them something that they can leave with, that they can put into play right away. So one of the things I'll do is I'll say, so how are you coping? How have you coped in the past? When something challenging has come up in your life, how did you deal with it? People may have adaptive coping strategies and maladaptive coping strategies. So first I just start with asking, what are you working from? Identifying coping strategies that are maladaptive. I'll say, well, that's one way, that's one way of coping, but let's see if we can come up with some other ones that might be a little more effective. So some examples of maladaptive coping strategies that we see all the time. Substance abuse is a big one. Particularly with anxiety, avoidance is a big one. Avoidance and anxiety often go hand in hand. They're best friends. And I have a little star beside avoidance because avoidance is, sometimes we may think avoidance is good. Well, I need to avoid those people. But I like to draw a distinction between avoidance and setting boundaries. Setting boundaries, adaptive coping strategy. Avoidance, not as effective. And certainly being in dysfunctional relationships. Relationships are a great way of coping. Not all relationships are created equal. So I like to focus instead on accessing a support network that is supportive, exercise, meditation, and so many others that I'll get into in a little bit. So in terms of teaching new ways of coping, one place that can be helpful to start and sort of a concrete framework to give some clients are some CBT techniques that you may already know. And again, I don't live and breathe these, but I find that they're often a good place to start when somebody is really, really overwhelmed. They may not be able to really articulate where they're at. It's just like, it's everything. I'm a mess. It's everything. So CBT kind of does a nice job of giving a concrete structure that people can grab a hold of. Okay, well, I can do that one thing. I can make sure that I go for a 10-minute walk once a day. Other CBT techniques, exposure is a way of dealing with avoidance. So one thing we know about anxiety is if that thing right over there makes me feel anxious, I'm going to go do that thing. So exposing ourselves to whatever the thing is that's making us feel anxious, and to develop some competence and make that thing, whatever it is, less scary. Thought records are some, and if you have any questions about any of these, just feel free to email me and I can send you some resources. Identifying core beliefs, getting at any kind of critical thoughts, gets at some self-esteem stuff. Tolerating uncertainty, I find, is a big one. Tolerating uncertainty is a theme that comes up a lot with sort of a generalized worry or a generalized anxiety, and certainly it's something that's very relevant for PHAs. And then also I talked about a little bit behavioral strategies, like getting back to doing things that I enjoy doing, pleasurable activities, getting out there. And what we know from research is that by starting to think differently and by changing our behavior, we change how the brain looks. So it doesn't have to be all medication based. We can actually change our mood, change how the structures of the brain look by changing how we live our lives. Other new tools for coping, one that I really love, mindfulness meditation. We know from the research that mindfulness meditation helps reduce depression, it helps reduce anxiety. It's good for our physical health, it's good for our mental health, it's good for immune function. And there's a really interesting study that looked at patients that were waiting for back surgery. They were waiting for a spinal fusion and they were in incredible amounts of pain. They did a mindfulness-based stress reduction course, and some of the patients actually opted out of surgery because they were able to manage their pain so much, so effectively with mindfulness meditation techniques. So it's a really, really powerful tool. Self-compassion through empathy, dealing with critical thoughts, dealing with shame and guilt, like Jordan talked about, acknowledging the client's resilience, and capitalizing on their strengths. All of our clients have strengths. All of our clients have had challenges in the past that they've overcome. We don't need to start from ground zero. They already have the tools. It's our job to empower our clients so they can access those tools that they've used in the past and help them tweak them so that they can move through this current challenge, which is just one of many that they're likely to face in their lives going forward. One thing that I always like mentioning is that the therapeutic alliance and the process of meeting with our clients is a creative process. So just really being open to listening to your client and working creatively with them to come up with strategies that are going to be just their unique recipe for getting through this challenge at this time in their life. Resilience is the ineffable quality that allows some people to be knocked down by life and come back stronger than ever. Rather than letting failure overcome them and drain their resolve, they find a way to rise from the ashes. Psychologists have identified some of the factors that make someone resilient. Among these are positive attitude, optimism, the ability to regulate emotions, ability to see failure as a form of helpful feedback. Even after a misfortune, blessed with such an outlook, resilient people are able to change the course and soldier on. So in the interest of time, I want to make sure that we really get to our case studies that we have for you. So we might as well skip this one, I think. Just briefly, therapy, our sessions with our clients can look like a number of different things. It can be crisis management, it could be psychoeducational, it could be supportive counseling, it could be case management. The important thing to remember is that every client is unique and to just really meet them where they're at and use that as a starting point. We've got here, where can I refer somebody if they need help? Again, these are just a few. These are a few services that Jordan and I refer to on an ongoing basis. And certainly there are others, but Casey House, PWA, ACT, David Kelly, Women's Health and Women's Hands, the program at Maple Leaf, where we're lucky enough to be able to provide free psychotherapy. There are various hospital programs at Mount Sinai, St. Mike's, Toronto East General, CAMH, of course, Family Services, Catholic Family Services, where they have free or pay what you can psychotherapy, and then, of course, always a psychologist, social worker, a psychotherapist.
Sometimes you meet clients who are HIV positive, and it's no big deal. It really isn't. It's like, whatever, I'm coping. It is what it is. That's all right. They're not in denial. It's the other thing. They're in acceptance. And they just see it as, just something, a part of my life that I guess I have to think about once a day when I take a pill. But other than that, no, it's cool, it's fine. It's just a part of me, and that's great, and that's okay. And then the people on the other side of the spectrum who are like just horrified, like, what kind of monster am I? And it's the end of the world and the whole thing. And then, everything in between. But the first people that I mentioned, the ones who are like, it's not really that big a deal. Like, it's interesting. Like, we're seeing more and more of that. Right? It's sort of a newer generation who's coming up. very often when you tell someone you're HIV positive, it's like, oh yeah, I'm gay, right? Or, hey, guess what, I'm gay, oh yeah, I'm HIV positive at the same time. It's sort of like the 1-2 punch for a lot of people, which is like it's crazy disclosure, like if you think about that. And so, when I talk about anticipatory anxiety, which is huge for everyone, it's always the fear, right? And we can probably all relate to that idea of the fear of doing something and going through life is always going to be way worse than when you actually do it. Even if the outcome is negative, the anxiety that you've put yourself through to get to that moment of disclosing is way worse. And in fact, a good friend of mine once said to me that ambiguous hell is always much worse than definitive hell. And that person was Sarah Lyons. And she said that to me 6-7 years ago, and it's stuck in there with me. And I say it to people all the time because it's true, right? The not knowing is always going to be worse than knowing, even if knowing is a bad outcome, for sure. When I meet brand newly diagnosed people, I basically advise them not to disclose. Because for this whole thing around adjustment, issue, disorder, whatever we're going to call it, is a process, right? And I'm constantly saying to people, the way you're feeling right now, the way you're going to feel in 6 months, the way you feel in 1 year and 5 years from now are going to be radically different. So let's let that process do what it needs to do till you're more comfortable. And at that point, but disclosure is an issue when the client is saying to me it's an issue, right? For me, you know what? One of my tenets has always been a problem isn't a problem unless it's a problem, right? So it's up to you to tell me what a problem is. I'm not going to be the one saying that to you.